Okay, hello everyone. Welcome to the first affiliated hospital, Harbin Medical University in Heilongjiang Province, China. And I'm Li from the cardiovascular department. And firstly, please let me to introduce my team today. The moderator is Professor Chao Yang.
Hello.
So the second operator is Dr. Dong Guo.
Hello.
Zhiyu, Wang Dingyu, and the senior tech is Song Pengwei. So we really think it's very glad to take part in the MyStream 360 project to share with our experience in chip PCI. And firstly, please let Dr. Dong to introduce the case.
Okay.
Show the slides. Okay.
Hello, everyone. I'm Dr. Dong. And first of all, let me introduce the operators and the moderator. First operator is Professor Li. And second operator is Zhao Jiyi, Wang Dingyu, and me. Moderator is Professor Cao. Next. This patient is 69 years old male, and the risk factor is hypertension and smoking. This patient suffered from chest pain for 5 months. An injection fraction is 67%. And electric cardiogram shown negative T wave in leads of 3 and IVL. Next. This is the first operation in other hospital. The patient performed this operation on November 17th. And you can see in this imaging, there is a subtotal occlusion in the proximal of circumflex. Next. Normal left anterior descending. Next. Proximal right coronary artery, there is total occlusion. And you can see lateral channel to the proximal of right coronary artery. Next. During that operation, circumflex was treated with dragon lutein balloon. Next. At the end of the operation, there is no significant dissection and hematoma. Next. About 2 months later, that is February 1st, the patient came back and do another operation. During the operation, we can see there is almost 30% to 50% stenosis in the middle of circumflex. Next. Normal LAD. Next. And the operator tried to open proximal occlusion lesion of right coronary artery. However, unfortunately, the guiding wire failed to enter the true lumen. Next. This is the end of that operation. That's all.
Okay. So Dr. Dong already introduced the case, and we can see that this is a 2 coronary artery occlusion case. The circuit is subclusion, and in the first time PCI recanalized and used vacuum balloon to treat the lesion. And the second time PCI, we can see the and the RC proximal is total occlusion, no stent. And during the second PCI, failed to recanalize the RC CTO lesion. Certainly, the operator make a mistake, didn't use dural angiography. So let's see today's angiogram. So the audience, today's angiogram, please. Okay, today's angio. Okay, we can see today's coronary angiogram. We can see the circle is still patent. but with lesion. So firstly, we use QFR to evaluate, to assess the functional flow. Dr. Wang Dingyu, please show the audience the QFR result of the circ. Dr. Wang, could you introduce the result of the circ?
The QFR today of the LCX is 0.76.
Yeah, okay. So the QFR is quantitative flow reserve, and that means use the coronary angiogram to assess the functional of the circ, and we can see 0.75 in the boundary. In the boundary. Yeah. So I think today's target vessel should be the RCA. And okay, so this is the epicardial view of the circ. We can see still, we can see diffuse lesion in the proximal and the middle portion of the circ, and relative large circ. And this is a RAO crinal view. We can see this is the LED. We can see several septal channels to the distal RCA, and okay. So let's see the, this is the LAO view. We can see this is the collateral channel from the left coronary artery to the right coronary artery. And really, this is no stamp CTO, and just at ostium of the RCA, there are two dead branch. We couldn't make sure where is ostium of the RCA lesion. So for this kind of case, we think the CTA should be very helpful. So we made a CTA for this case, and also do 3D reconstruction, use a software made by our team. Professor Wang Dingyu, please show the audience 3D reconstruction of the CTA, and we can see this is a common CTA. And next. Okay, so the 3D reconstruction of the vessel, you can see in different color, and for the different vessel, different kind of plaque, and we could rotate the imaging freely in any direction, and we also could delete any of the vessel of the plaque to have to well understand the CTO lesion, and we can see we already deleted the left coronary artery and delete the aorta. Okay, delete the calcification lesion and rotate a little bit. Okay, rotate a little bit. We can see three that branch, and the brown one, left anterior oblique. Please show the left anterior oblique. The brown one is the CTO segment, but this is a relative soft tissue. And the white one is the calcified lesion. So we could, okay, delete the brown one. Oh, okay. So we can see delete the relative soft tissue. We can clearly see the calcification, the relationship between the calcification and the Truman. And we could zoom in, enlarge the imaging a little bit. We can see just at the ostium of the CTO lesion, there is a relative large calcium plaque. Dr. Wang used the mouse to show the audience where is the proximal calcification. Okay, can you use some? Okay, so just at the ostium of the RCA. Okay, at the engine. And also rotate a little bit. We can see just at the distal cap of the RCA, CTO lesion, the distal cap, there is also a relatively big calcified lesion, and the calcified lesion almost embrace the true lumen of the distal RCA, and mainly locate in the outer side, in the anterior side, and in the back side, but in the inner side, maybe no calcified lesion. So that is why the second time PCI failed, because ostium of the CTO there is a calcified lesion, the wire difficult to cross, and once the wire go to not in the architecture of the vessel and go outside of the distal lumen. So because there is calcification, it should be very difficult to re-enter into the distal lumen. And we also can see in the distal portion, zoom out a little bit. We can see, okay, zoom out a little bit, rotate at AO view, okay, at AO view, okay, a little bit at AO view. We also can see in the second part and the third part, the connection area of the RC, there is also very big calcified lesion. So if the wire go outside, it will be very difficult to enter into the distal lumen. So for that kind of case, CTA 3D reconstruction give us many information, will help us to make optimal strategy for this case, and where to re-enter in, and how to select the wire, and maybe where to choose optimal landing zone for ADR. Yes. So, but certainly because this is so we could make know that for that case the GCDO score is 3. Okay, no stamp, first the PCI field and calcification. Yes. So for this case, we did bilateral angiogram. So let's see the bilateral angiogram. We can see, okay, really in the distal RCA diffuse lesion and with calcification. So no stamp. So firstly, we decide to use IVAS to find where is the ostium of the RC first. Okay. So the audience, the IVAS, please. Okay, the IVAS, please. Please light monitor Dr. Cao Yang to introduce the IVAS. Okay.
Okay, so now what we see is the run from the cornus branch to the proximal part of the RCA. We know this is a total occlusion, lesion. So we can see that from the set branch during the pullback, we can see there are several predictors for the antegrade failure. First one, there is a very short segment from the ostium RCA to the occlusion entry point. So from the pullback, we can see that there is another set branch joining in the main vessel from 6 o'clock. But this is just another branch. This is not the main vessel. If we go more proximally a little bit, from here we can see, let me make a dynamic view for you. We can see this main branch with some mild to severe calcification into the plaque, just like the professor just indicated that this kind of calcification in the main branch. This is the main branch joining into the main vessel from 9 o'clock. So this one is a perfect entry point for the true lumen, I think. So this is the key information from I was guided from the set branch, Professor Lee.
Okay, so the IVAS also showed that just as the ostium of the proximal cap, there is a fibrous cap. So let's see the angio. So in such condition, we will use manual imaging, IVAS imaging, to find where is the ostium of the RCA and to make sure where is the ostium. And then next we use Corsair microcatheter and the CP wire to puncture the proximal cap. Okay. So okay, let's see. This is also a bilateral angiogram. Okay. Okay. So here is at present where the wire is.
Okay.
So next, I will try antegrade wiring. And if the wire go to the subintimal space, so if we try parallel wire technique, because we already know where is the calcification, we should go a little bit inside the RC. We have more chance to re-enter into the true lumen.
Yes.
But if the parallel wire technique field, because RC distal true lumen with relative high plaque burden, I may try retrograde approach. This is today's my strategy.
Okay.
Okay.
So Professor Lee, I see that there are several, collateral flows from the septal to the distal RCA. So your preference for this one is antegrade first, right?
Yeah, I think we should make antegrade at least preparation. Even we choose the retrograde approach, I think we should make antegrade preparation because certainly for that case, we may use retrograde approach because severe calcification,
Yes.
no stamp, many difficulties. Okay. So now I'd like to advance a little bit to the Cochlear. So let's see if the Cochlear could be advanced. Okay. So if the Cochlear could be advanced a little bit, I may down the excitation, the antegrade wear, maybe Gaia third. Okay.
Okay, so we see that Professor Lee is working on the antegrade wire, and here is some key information I'd like to emphasize. I think Professor Lee has just made an perfect demonstration of 3D CT angiography reconstruction, which 3D reconstruction image, offered a lot of key information in this case. Just see that there is very detailed information of the calcified plaque at the proximal part, especially at the entry point of the CTO segment, which explains the previous PCI failure. Why? It's really high risk of going into the subintimal space because of the plaque. And also in our center, under the leadership of Professor Lee, we make full use of CT angiography image to perform like this one, in this case, the 3D CT angiography reconstruction. For the strategy, for the detail of the plaque, etc. And also, there is one unique, techniques called CT angio FFR, which is created by our team. And we combine the angiography, CT angiography, to make an analysis of the functional evaluation for the coronary artery, which highly, raised the accuracy of the functional test. So I think that CT angiography is very important and it's popular used in all the hospitals. We should make full use of this, information to help us to get us our procedures and also even the prognosis of the patient. So I think that for the current PCI, Professor Lee just mentioned that he is trying the antegrade first using the parallel wire technique. And here I think that this is for me, we know that Professor Lee is a high volume CTO PCI operator, but for me, that's so for example, the experience is not so rich. I think this is pretty tough because this is a second-hand, case. First one, for me, I will worry about whether the former dissection of subintimal cavity has healed or not, because we just spent for 2 or 3 months from the previous failure antegrade approach. And also, even though the occluded segment is not so long, it's within 20 millimeter. However, just like Professor Lee mentioned, the proximal part, the ostium RCA to the entry point of the CTO segment is quite short. And also we notice there are 2 stat branch at the proximal part of RCA, which all increase the risk and difficulty of going into the true lumen. So I think that bifurcation as a proximal part, they can offer some help. For example, you can do IVS to check the entry point, whether it's true or not. However, it's caused a lot of difficulties for getting into the true lumen like this one. And also the calcified plaque may cause a lot of difficulty to block you into going into the intraplaque area. I think Professor Lee has just made some progress from the antegrade wire, and we are using the collateral flow from the contralateral to make sure the location of the wire.
So we can see the wire go a little bit outside the distal lumen, and so the true lumen should be in the right side. And as we know, the CT shows us there is a calcified lesion. In such place, may be very difficult to enter into the the treatment.
Yes.
So I like to use give me a Sasuke and okay.
So Professor Lee, you just mentioned
parallel wire technique. If parallel wire technique failed, we will rapidly switch to okay, counter O balloon.
Okay.
Switch to the retrograde approach.
Okay. So Professor Lee, you just mentioned the concept of vessel architecture. So I think this is more and more popular use nowadays. We seldom, mention about the true or false lumen. So the concept of vessel architecture increased our choices for the, strategies in CTO segment. For example, a relatively short segment of subintimal space without losing very big branch is quite acceptable.
Yeah, so generally speaking, the subintimacy should be the media. In the media, the tissue is very soft, so relatively easy to be enlarged. And if the where we can feel strong resistance, those conditions, that means the wear in the plaque, intraplaque.
So actually for me, I'd like to, whenever I meet a case of like this one second-hand case, I'd like to summarize some previous, failing predictors. Like in this one, we just see that on the previous PCI, the operator didn't perform bilateral angiography, which is, a very sad point because without bilateral angiography, it is hard to confirm the occlusion segment length and detailed information. And also, this kind of a blind puncture from the antegrid is gambling and risky, especially like this one. This complex calcification at the proximal entry point zone causes the subintimal tracking and also makes the current procedure a little bit difficult because we still worry about the healing of the entry point from the previous PCI. And also we can see, like we just mentioned, there are several collateral flows from the septal to the distal RCA. We are training the integrated parallel technique.
So I think what we can learn from this case is how to make full use of the CT angiography. Yes. And to show the audience the software we made by ourselves, how to make the 3D reconstruction of the CT imaging, and we can see the 3D reconstruction imaging could help us better understand the vessel and the CT lesion.
Yes.
And the plaque distribution, and will help us to better understand the CTO and to help us to make the optimal strategy.
Yes, just like Dr. Lee in the instruction, I think more importantly, I'd like to emphasize that for this 3D CTA reconstruction software, we possesses proprietary intellectual property rights for this domestic software, which means that this software is 100% China-made. So this is our pride. And also, I'm thinking that this kind of 3D reconstruction, CT angiography reconstruction, guided CTO procedure is of potential benefit to the patient for the prognosis. So maybe this kind of strategy using the software may raise the successful rate of the CTO procedure. So we are switching the third from the anti-grid wire.
So use the Durham catheter to help to do the parallel wire technique. So many advantages could help us to easily advance to exchange wire, to increase the backup support. Okay. And sometimes also could significantly increase the puncture ability compared with common microcatheter.
So with the help of dual lumen microcatheter, we can easily switch the direction of the second puncture wire to choose, into the more proximal near next to the intraplaque area. Actually, in this case, I think that with a combination of CT angiography information and IVUS, we confirmed the proximal calcified lesion, which explains the antegrade failure risk factors. This case seems to be a clean CTO with blunt tip, but if you pay more attention in this one from the angiography, especially the bilateral angiography this time, you will find it could be troublesome. An RCA occlusion entry point is not so clear in this one. And also here we can see the first wire from the collateral flow doesn't seem to be into the intraplaque area. And Professor Lee explained the parallel technique. Of course, ADR is a potential strategy, but however, in this one, the various attempts may cause a subintimal space. ADR entry point should be not so distal to the RCA. Otherwise, it will cause a slow flow, which means the poor run off of the RCA. If you lose a lot of big set branches, the prognosis of the patient will be poor, especially for the myocardial infarction rate and also the target vessel revascularization rate.
So for the parallel wire technique, the key point is also called the contemporary parallel wire technique. That means avoid too much the wire first wire manipulation to avoid large hematoma and false lumen formation, and that may reduce the success rate of next time the wire coming to the true lumen. And based on the last angiogram, we can see the lumen should be in the right side of the wire. So the second wire should be go a little bit right side. Okay.
I think we made some progress with the Gaia third.
So bilateral angiogram. Okay. So orthogonal view bilateral angiogram is very important for the antegrade wiring. Okay. We can see. And generally, the second wire should be a little bit stiffer than the first wire.
Yes.
But why I choose Gaia third? First one is CT because CT angiography already show us in the inner side not very stiff calcified lesion.
Yes.
So I choose Gaia third.
Yes.
And the advantage of Gaia third is good torque response. Maneuverability, okay. Okay. But the feeling tell me should be also in the subintimate space. Sometimes the feeling is very important.
Yes.
Okay.
We can see that Professor Lee is using the contralateral collateral flow to confirm the wire location from the antegrade. It's not performing.
Restore a little bit. Go a little bit left side, maybe. So if this failed to come into the true lumen, I will try retrograde approach.
Okay. And also, like just Dr. Lee mentioned, the control of the antegrade hematoma is quite important because a lot of CTO cases, even though after the wire managed to re-enter into the true lumen, we can see a very long, very huge hematoma, which causes its a potential stenting strategy failed that we have to make investment for this kind of procedure. So the control of hematoma is quite important from the antegrade approach. And we are using contralateral collateral flows to confirm the wear position.
Okay, for this case, we choose by femoral approach because the radial artery would be used again.
Mm-hmm.
Assign to, and the patient also is to iliac stent in the iliac artery.
Mm-hmm.
So the patient is very severe atherosclerotic plaque. Okay, I think I should choose another relative stronger wear CP again.
Okay.
Okay.
So for this case, the CT angiography imaging
because,
after a lot.
If the antegrade wear could come into the distal trulum and the wear must be stiffer than the plaque. Theoretically,
yes.
Theoretically, the second wear should be stiffer and the curve should be a little bit larger than the first one.
Okay, to choose in the right direction.
Yeah.
So Professor Li, for you, do you worry about the previous PCI, dissection that the previous PCI caused that has not healed or not for this one?
Certainly, already 2 months.
2 months, yes.
Yeah. I think
it's okay.
Should be enough time for the healing.
Because some previous manuscript just indicated that the European people and the Asian people, their dissection healed time is a little bit difference. So the Asian people is likely to be quicker and better healed for the dissection part. So we have used 3 months to give this patient for the healing time. I think this is proper. And also another word for the circumflex. We just noticed that the previous PCI we used the drug-eluting balloon for the de novo lesion of circumflex. And for this short follow-up, we can see that the current FFR value is quite acceptable. And we are looking forward for the, future long-term follow-up. This kind of value could reach a little bit because we understand drug-eluting balloons could cause the plaque to shrink in the future follow-up. Although there is not quite strong, the big, studies for the DB use in the de novo lesions, we noticed something like several 50, 100, cases, clinical studies indicated that with proper plaque modification, the DB could be applied to the de novo lesion, especially for the long diffused high-risk patients. I think that this is a potential, benefit and strategy for this kind of patient. Especially for the CTO segment. A lot of CTOs, especially after the instant recanalization, for long time of, the vessel shrink and spasm happened, which is a very high resistance. So the instant stenting strategies might not be a good choice. So the DB use for the CTO procedures for long diffuse and small vessels could also be another choice.
So we can feel really the plaque is.
Yes, because CT indicated a lot of calcium, like you just mentioned, it's embracing the whole vessel. So it's hard to choose the entry point. You have to make very precise puncture.
On the angle, we also could very if we are, we pay attention to the guiding.
And also the 2 set branches as proximal part could be troublesome because we know CTO with bifurcation is relatively hard to puncture into the center part because of coaxial, direction of the gating catheter, and also the set branch.
Okay, I think if that's time field, I will try retrograde approach. Okay, sometimes rapid switch is also key point for the hybrid strategy. Okay. Okay, Andrew, retrograde. On resistance.
Yeah.
Okay, I think should be in the wrong direction. Okay, let's switch to the retrograde approach. I think we should. Okay.
How about this one?
Okay, Andrew.
Yes, I think the tip is wiping freely. Would be good. Some good information.
No. Okay.
Okay. So the good news is
the subintimate space, but I think we already make good integrate preparation for this case. Okay.
So Professor Li, what do you think about the ADR for this patient? Is this a good choice or not?
Yeah, certainly we could try ADR. Okay. Across 150. But the CTA showed us, and also the bilateral angiogram, we can see the plaque burden is relatively high.
Yes.
And in the distal cap, CTU cap, there is severe calcified in the outer and anterior and back side. So, and in the connection area of the second and the third part of the RCA, so in this place should not be used for the re-entry zone.
Yes.
Yeah, but for this case, I think we could try a retrograde approach. And okay, so sometimes if we have the retrograde wear as a landmark, the precise wear sometimes also could suffice.
Yes, we still have a chance for the kissing wear.
Renal view. Okay.
So from the baseline angiography this time, we noticed the two relatively good collateral flows from the septal to the distal RCA. One is a little bit proximal to the vessel, and another is a relatively distal part. So both two septals seems to be CC2 level, CC2 level, something like a little bit, tortuosity at the mid part of the connection from the septal to the distal RCA. So we try which one is more friendly to us. Like just Dr. Li mentioned, the anti-ADR strategy, the entry point is quite important. For this case, we need to, avoid the proximal and mid part calcification part because it's relatively hard to make the re-entry into the intrapark. And also, we noticed that there is a relatively moderate to big size set branch at the mid part of RCA. So losing this one could not be a good choice because it's affected the prognosis of the patient in this one.
Okay, so sometimes we could try septal wear surfing, and as been reported for the septal wear surfing, the success rate is about 81%. And but before the surfing, I like to do a contractile injection.
Yes.
Okay.
You can see Professor Li is performing contrast guided. Yes.
Okay, please.
We're using the macrocaster to make a high selection angiography from the collateral flow, pathway, the CC level, and also the tortuosity, which helps us to make the surfing. So Professor Li, what wire are you using for the retrograde wire crossing?
For the retrograde wire crossing, maybe for different lesion, we choose different kind of wire. Sometimes when we do reverse cut, I like to use relative stiff wire like Pilot 200, CP, Gaia.
So for the retrograde wires, now we have, I think, multiple choices. Preferred wires for the septal crossing are composite core, soft guide wires for me. for my preference, such as the Sim, we have Su03, and the Samurai RC, etc. I mean, these are all soft polymer jacket wires, such as Fielder FC, Fielder XTR, etc. I mean, all these wires are great in manipulation, and also the torque response for me is relatively good. However, for the extremely tortuous septal collaterals, for me, I mean, 203 is a good choice since it's designed of, there is a 7mm at tape without core design, increase the flexibility, trackability, dramatically.
A little bit.
Okay, we see that Professor Lee has just brought the septal, collateral so fast.
So we'd better advance a little bit further the retrograde Sion wire, give more backup support, and see if the front cross could cross freely. Okay. Okay, a little bit resistance. It a little bit anti-grid guiding.
Okay.
If the fan cross couldn't cross, we still could use Carol well.
Yes.
Yeah, okay. Advance a little bit.
Yes.
Okay. Okay.
Because we can see.
We can see still we can feel resistance. Carol well, please. Okay. Carol well. Okay. So in such condition, Dr. Chao, you could show the audience how to treat this kind of problem.
Yeah.
The wire crosses septal collateral channel, but the microcatheter couldn't cross.
Yes.
So how to treat?
Actually, for the retrograde approach, this kind of problem is quite, often seen in the clinical daily work. The wire passed, however, due to the tortuosity or angulation, the macrocatheter cannot pass. I'm not quite sure, Professor Dong and Professor Lee. For me, I'd like to switch to a more friendly macrocatheter, like the Caravel.
So
small caliber, yes.
That is a good choice. But sometimes we could use Cosea microcatheter to cross. And the Cosea microcatheter, we call this panel dilator. Okay, sometimes after the Cosea, after the Cosea couldn't cross, may enlarge the septal collateral channel, and then like the front cross may cross.
Yes.
Okay. So, okay, inflation 20. So if still couldn't cross, sometimes we also could use small profile balloon to cross, because we can see, as we know, the small profile balloon, the crossability is good. So Carawel, okay, Carawel. So then we can use the small balloon to cross. I dislike to inflate.
Oh, really?
Certainly, some operators suggest we could use low pressure 2 to 3 atmosphere to inflate, but for me, I dislike.
Yes, we don't want to see some contrast. Residue from the septal.
Also, the septal collateral channel perforation in most conditions is benign. Sometimes also could deflate.
Actually, the macrocatheter.
I invent a technique we call to use the front cross macrocatheter assist the silk suture or observable suture embolization technique.
Yes.
It's very useful for the small vessel perforation.
Yes.
Okay. Let's see if we could cross. So for the Carawel microcatheter, sometimes we could rotate a little bit, but not too much. Certainly for the Cosea, okay. Let's see if we could rotate a little bit, make some progress. Okay. Keep it a little bit guiding.
So the Caravelle is a smaller caliber. Yes, we can see it passes through very successfully.
Progress. We must be careful.
This is a good demonstration, I think. without using balloon to dilate, that we switched to a more, flexible and smaller caliber microcatheter. We successfully forced the collateral flow.
We can still feel the resistance. And one tips and tricks for the retrograde for the CTO PCI is most condition we should put workhorse wear in the YSO to make the guiding stable. And okay, I think some resistance. Okay, doesn't matter at AO view.
Okay.
In such condition, sometimes we could use a retrograde wear as a landmark. Okay, at AO. Okay, at AO.
Okay.
Okay. So we can see the wear already coming to the marginal branch. Okay, here.
Antegrade wear seems to be quite close.
Okay.
We're quite close to the.
Sometimes we could try parallel piecing wear technique. And the tips and tricks is make the retrograde wear straight to better work as a landmark.
Yes.
Okay. Then talk, please. Okay, talk, please.
Actually, from this one, we can see the antegrade wear is quite close to the intraplaque area.
Very close. So really, so in the a little bit right side. Okay. Why?
Like Dr. Lee just mentioned that actually we could perform ADR for this one very easily, but that may cause, or to say, an unpredictable subintimal tracking space with losing some set branches. And also we know this kind of procedure will cause a little bit.
We need the different orthogonal view to see, okay.
So try to maintain the whole procedure within the plaque is a promise for the good prognosis of the CTO patient.
Here should be the calcified lesion. Here, okay.
So Professor Lee, the antegrade wear is still Conquest Pro, right? No.
Retrograde wear?
Antegrade.
Yeah, still this. Okay, RO view. So the orthogonal view is very important for seeing where.
Yes, to make sure.
Yeah.
The location of the tip of the band.
Okay, so we can see where we're a little bit wrong to the left side. Draw a little bit in the direction. Okay, at you.
Actually, I'm just right standing at the back of Professor Lee, so I noticed that Professor Lee make a relatively small band with antegrade wear, something like 1 to 2 millimeter long. 45 degrees of the distal band. So with the good manipulation, we can see we can make a very accurate puncture.
Okay, RO view. You can see the two were very close.
Very close.
Okay, RO view.
Almost at the same location. From different projections.
So the orthogonal different view is very important.
Yes.
I think I can feel no resistance
at
present. Maybe could be in the trolumen.
Yes, at least in the within the plaque. Yes.
Left corner tree. Okay, a little bit. Test a little bit. Okay. Andrew. Okay.
I think we are in the yes.
Aerial view. So we should use different view. Could withdraw a little bit to the retrograde wear.
Okay.
Okay. I think in the distal trolumen.
Yeah, I think.
Okay.
Yes.
Okay. Okay. Oh, okay.
That's a good one. Yeah.
I finished this operation.
Yes.
Okay.
With the retrograde wire as a landmark that we can see we choose the right direction and finally it goes into
certainly
the
if the antegrade kissing were filled, we still have many choice.
Yes.
Yeah. Just like I said, we could use PCI to dilate the septal channel and then exchange parallel again, sometimes we cross.
Yes.
Or use a small balloon. So, but what we must pay attention to is when we final, we externalized the wire, we must check the septal channel.
Yes.
And we should pull back the macro channel, macro catheter to the donor artery and do coronary angiogram. So if there is perforation, it doesn't matter. So antegrade and retrograde stent cross macro catheter and use 3-0 absorbable suture and the about 8 to 10 millimeter length and put inside the fan cross macro catheter and use the workhouse wire to push the silk suture to the perforation site. And the key point is to keep the fan cross macro catheter stable. And after the workhouse wire, the tip get the tip of the macro catheter, we can feel the absorbable suture already pushed out of the macro catheter, and then pull back a little bit to the fan cross macro catheter, and then push another silk suture. And according to my experience, after 3, most conditions about 2 to 3 absorbable suture embolization to coronary angiogram. Yes, maybe okay. Already is sealed by the. So the function is just like the coil, but the coil have cost and very ugly. Yes, so yes. What it's like. So certainly we already published our experience. So audience, if want to try this technique, you could read the article. Okay. Yeah. I know Professor Lee has some series of studies about this one. It's called the successful occluding by absorbable sutures for epicardial collateral branch perforation. Yeah. So if for the distal vessel perforation, sometimes we'd like to use silk suture. Yes. Silk suture. Silk suture with small fur on the surface of the suture. So maybe better to embolize the perforation. Yes. But we must pay attention. We need to use very sharp knife cut. Yes. Not to let the silk suture release. Be stuck inside the cross macro catheter. Okay. Yes. So, okay. Any question from? Yeah. Do you have any questions? Actually, I think that this technique is quite good because absorbable sutures does not leave anything behind. So in the future, that it will heal by itself. Doesn't like the coil that it will live permanently into the body of the patient. Okay. So next, I think we should exchange because it's very stiff. So I think we should the guiding is sealed. Short tip left 1.0. In order to increase backup support, I may put a small balloon in the honest artery, and and to increase balloon anchoring. Yes, yeah, and use small balloon to dilate the CTO lesion first, then exchange a common microcatheter. Okay, yeah. So I think 1.5, 2.0, yeah, 2.0 to exchange the Sasuke. Okay. Should exchange the Sasuke? Yeah, okay. So for this case, I'd like to summarize that with the 3D angiography reconstruction, we acquire a lot of detailed and very important key information for this one to make sure the proximal part composition, especially the calcification location. Yeah. Yes.
So like Dr. Lee just, performed the
And
anti-grid.
3D reconstruction imaging also could be rotated.
Yes, yes.
Any direction.
Mhm.
I mean, from
We can
very
interact.
strange view to see
Yes,
where is the
Yes,
calcified lesion, where is the lumen, where is
Yes.
the soft plaque,
yes.
how the side branch
Mhm.
distribution. Yeah.
We can interact with the software to choose which part and to rotate the image, make more precise, threat release for this one. And also, we can see that anti-grid, puncture failed because the wire goes into the subintimal space because we need a clear direction with the retrograde wire as the landmark that finally the anti-grid wire goes into the
So for the next case, we also use a 3D reconstruction app, the operator to see all the calcified lesion distribution. The next case should be use the shockwave system, and we will use China-made special imaging machine. So integrate the OCT and the IVAS to better see the calcified lesion. So at present, really the imaging guidance very, very, very important. We must make full use of the imaging and functional guidance.
Yes.
Okay. So I think time is over for us. Okay, you can move on to next case slide.
Okay.
We are ready. I think we are ready. Finished. So already move on to next case lab. So I think we should give the next case lab enough time.